Hi, everyone. Welcome to those of you who are joining. It's so great to see everyone this afternoon. We have a great group today, so we will just give people a little bit to join. Hope that everybody is having a wonderful Tuesday so far and a good start to your year. In January, we're looking forward to a really robust and exciting conversation today. So while we still have people joining, I will just go through a couple of introductory slides before we get into things. First, want to introduce the team that will be here today. I'm Pam Dardis, Vice President at the Institute for Patient and Family-Centered Care. I'm joined by my colleagues Jasmine Arazi and Deepa Ganachari. Matt De Silva, as usual, will be handling all things technical. We have some other IPFCC folks on the meeting today. We've got Bev Johnson and Marie Abraham. Everybody will be hanging out in the chat, so we look forward to learning with and hearing from all of you. Next slide, please, Matt. We have heard from our community how valuable these PFCC Connect conversations are, and just wanted to thank our sponsors. We are able to offer these conversations due to the generous support of our PFCC Connect sponsors, Kaiser Permanente and University Health. So thanks very much to them. Next slide. We also would like to thank our Pinwheel sponsors. So these are organizations that help support our work while gaining visibility and recognition for their commitment to patient and family-centered care. To learn more about our Pinwheel sponsor program and to see our current sponsors, learn about benefits that are offered to this group, Deepa is actually going to put a link in the chat. You can click on that to learn more. Next slide, please. So those of you who have attended a PFCC Connect conversation before will be very familiar with these group agreements. These are designed to encourage active participation, idea sharing, positive interactions that build and strengthen our community of people doing work related to patient and family-centered care. And our conversation today is really designed for active participation. We encourage you to ask questions and share ideas. You can raise your hand virtually. You can use the chat. You can react. Our chat is always very active. Please take a moment, introduce yourself in the chat, say hi to everyone. We will be monitoring that along the way as well. If you do have any technical difficulties during our time together, please send a private chat to Matt De Silva, and he will help you try to work through those. We also do want to remind folks that we are recording this conversation today. We do make these recordings available to members of our PFCC Connect community. Next slide. So when you registered for this conversation, we asked you to include any questions that you had about the topic. We took a look at these and they fell roughly into these six topics. So people had questions about diversifying PFAC membership. They wanted to talk about and learn about strategies for outreach and recruitment. There was a set of questions around how to build and strengthen community partnerships. Questions and comments around supporting patient and family advisors, including creating environments that are welcoming. There was a set of general questions about PFAC structures and operations and processes, best practices, essentially. And then a couple of questions about how to navigate challenges and move work forward in the current environment and landscape. So our goal is to have time to touch on most of these topics, but we do have a lot to talk about. If we find that there's more to talk about, we can always have a part two to a conversation as well. Before we get into our conversation, we did want to share a bit of exciting information with you to set up our conversation today. Next slide, and I will turn it over to Jasmine Arazi.
Thanks so much, Pam, and hello, everybody. Today we have the privilege of sharing with you all a new toolkit that is based on over 5 years of work by IPFCC, and this work has been supported by the Lucille Packard Foundation for Children's Health. It includes a national survey of children's hospital PFAC prevalence and practices that was conducted back in 2020, an identification of gaps and needs based on the analysis of that survey, and extensive work to collect and share practices from hospitals and others that have successfully navigated some of these key challenges. We will put links in the chat to resources and articles that were developed as part of this work previously, and we really encourage you to take a look at them when you have the opportunity. However, this new resource that we have developed and are highlighting today is called the Reflecting Our Community, a toolkit for strengthening PFACs, and we will put that link in the chat separately. The new toolkit includes specific guidance. It includes tools to support progress and numerous examples from organizations that have implemented successful practices related to strengthening PFACs. The toolkit was informed and reviewed by a National Project Advisory Committee and a working group consisting of individuals that provided key insights and perspectives. And they are acknowledged in the toolkit, and we greatly appreciate their support. I also see many names and faces on the call today who have also contributed to this work over these past 5 years. Everything from completing the survey to participating in interviews with us to sharing resources with us. There's too many to name, but we thank you all for your participation and your partnership throughout this journey. Just a quick overview of the toolkit. There are 7 key areas. The first is a PFAC assessment that we encourage all hospitals to review, discuss, and complete. We have heard from hospitals that have completed the assessment that the process is eye-opening and just an extremely useful exercise for identifying strengths and areas of opportunities. There is also an action plan template and guidance to support you in identifying specific goals and creating a plan for action that is realistic and one that supports progress. There's information about ensuring representativeness in recruitment, creating a welcoming environment for PFAs by addressing any barriers to participation, engaging PFAs in work that addresses issues related to health equity, and assessing and reflecting on your progress. So, many of the same topics that you all mentioned when you registered for this conversation. We are really encouraging everyone here to look, explore, save, come back to, and share this resource with others. And again, thank you so much, and we're just so excited to share this work with you today. Back to you, Pam.
Thanks, Jasmine. Appreciate that. Next slide, Matt. The other exciting piece that we wanted to share about this work is that there has been a community of hospitals who have spent the past year using the toolkit to advance their own practice. So with funding from the Lucille Packard Foundation for Children's Health, IPFCC structured a private learning community to bring together children's hospitals to advance the understanding and practice of patient and family advisory councils through transparently sharing their own work, ideas, successes, challenges, and lessons learned. Next slide. The learning community began with a call for applications in late 2024, which seems like a while ago now. Time has flown. To participate, hospitals had to identify teams that included an executive sponsor, the individual or individuals responsible for day-to-day work with PFACs, others who could support the work. So we had people from quality, safety, patient experience, and at least one patient and family advisor on the team. We also asked teams to articulate clear goals for participation that were related to diversifying their PFAC, creating an inclusive environment, and engaging patient and family advisors and health equity related work. We had An overwhelming response. We had 30 children's hospitals apply. 27 hospitals completed the 9-month learning community. There were actually two cohorts. We initially intended only one, but thanks to the generous support of the Lucille Packard Foundation for Children's Health, we were able to offer a second cohort. We had one cohort that began in January 2025 and one cohort that began in April of 2025. Over the course of these two 9-month learning communities, hospitals made progress in what was obviously a challenging environment. We did have to make some strategic changes along the way and just wanted to share a little bit about those with you. So, for example, one of the things that we did is that we revised language around this work. We originally had called this the PFAC DEI Learning Community. We This opportunity actually was helpful to us to be clear as a group about our goals. So, for example, when we talked about making a PFAC diverse and inclusive, what does that really mean to have a PFAC that's diverse and inclusive? So, it's an opportunity to clarify the language a bit. Some hospitals also let us know that timelines originally developed as part of their action plans needed to be more fluid and flexible as they worked internally to make sense of a challenging federal landscape. Everyone was welcome to continue in the learning community as long as there was a continued commitment to the goals. We were very clear that the goals of this work remain the same, that it's to ensure that PFACs are reflecting and representative of the communities that they serve, that there is a safe, welcoming, open environment for learning and for partnership, and that patient and family advisors are engaged in the work and strategic priorities of the hospitals. Prior to releasing the toolkit, one of the things we did was to consult with our learning community hospitals, particularly in the first cohort, who were a little bit further along just in their timeline about toolkit language. As a result, we believe that the toolkit provides an example of how to talk about and continue prioritizing key issues related to strengthening PFACs in today's world. So definitely encourage people to take a look at it with that eye as well. Next slide, please. In the interest of kind of getting to our conversation, we won't spend a lot of time here, but included the slide so that you can come back to it after the conversation to see the topics that we did address through the learning community. We had monthly meetings, and then hospitals went and, developed their action plans, and then also over the course of the 9 months made progress with their action plans. Next slide, please. We did want to share some of the key topics that rose to the surface during our time together as a learning community, some of which I'm sure will come up during our conversation today. But one of the key topics was really building trust through authentic community partnerships. So we talked a lot about relational versus transactional interactions, really just emphasizing the importance of building presence and trust in the community before making requests. Hospitals shared strategies for meeting families outside the hospital walls. And some examples included making connections with Latino wellness clinics, going to grocery stores and, chatting with people in the grocery stores, wearing patient and family advisor t-shirts and things like that so that people would ask you about it while out in the community, schools, and then also housing groups. And really, what was emphasized here was the importance of mutually beneficial partnerships. So, being very clear what is in it for the community to think about the Patient and Family Advisory Council and how does this benefit the community. The next thing we heard was strategies for diverse recruitment and representation. This was a significant focus. We had hospitals who talked about data-driven recruitment and collecting or reviewing demographic data about their patient populations and patient and family advisors to the extent it was available to identify gaps in representation when comparing advisors to the patient population. As a learning community, one of the things we also did was challenge the label hard to reach populations, reframing it as populations the hospital has been unwilling to go to or has not yet built that trust and relationship with. Hospitals also noted that representative recruitment often involves tapping into some of the internal roles within the organization that have some of these relationships. It might be social workers, interpreters, reaching out to people who have connections with school nurses and leveraging some of those internal connections. Next slide. So, in talking about strategies for creating a supportive environment, we touched on multiple topics, including compensation and valuing lived experience. So, moving beyond a culture of volunteerism to expand participation. We talked about training and education, including training such as unconscious bias training for advisors, preparing staff to support psychologically safe and welcoming environments, and developing frameworks for interaction that embody key concepts such as cultural humility and inclusive leadership. Um, Next slide, please. Finally, we talked about assessment as a tool for accountability and strategic planning, including the importance of creating feedback loops that are sharing results of the work with advisors and also yearly planning to align PFAC work to support hospital priorities. And as noted, we talked about navigating the current landscape. So this included concerns related to recruiting populations that may have concerns about safety and anonymity. So, for example, undocumented families participating in hospital councils, navigating issues related to trust of institutions, including healthcare organizations, and also structural barriers that sometimes make participation difficult, such as onboarding or volunteer requirements. And with that, next slide. One of the things that I do want to particularly call out about the toolkit before we get into this conversation is one thing that we were able to do over the 5 years of doing this work and through our work with the learning community, we gathered a number of examples. These examples are anonymized, but they are included within the toolkit. And actually, there is a page on the toolkit's homepage. The examples are embedded throughout the toolkit, but you can also see all of them at once. I think they are helpful to read through because they show what real hospitals have done in the real world related to some of these areas. And that includes things like the onboarding requirements and volunteer requirements. It includes things like recruiting, it includes compensation. So if you want to see some of those examples, I think the toolkit provides some great examples. And I know that all of you today will provide some other wonderful examples. But we're going to open up our questions and discussion now. And move into our conversation and just generally frame it as, what is it that you want to know from the community and what information do you have to share with the community? So that might be stories of success. It might also be challenges or even just ideas, things that you've been thinking about. I do want to acknowledge also that some of the questions asked during registration related to how to set up and structure a PFAC or PFA program more generally. We're going to put some resources in the chat right now that might be helpful to those of you who had these types of questions. We'll get those put in. Those are links to IPFCC resources. And of course, you can always reach out to us if you have questions as well. We do have a few folks who, in advance of this call, volunteered to share a bit of information about work that they've done related to this topic. So while all of you are kind of getting your questions and thoughts ready, perhaps we can jumpstart the conversation by asking them to share. And Teresa, I will come to you first to share a little bit about some of the work that you all have done.
Yeah, thank you, Pam. Um, so I am Teresa. I am a family partnership coordinator from Dayton Children's in Ohio. And I had the pleasure of being part of the second learning community and used the tools that were released today. They really did help center us and focus and pull a team together that could help overcome some different things that we didn't realize would be challenges at the beginning when we first came up with our proposal. So in the beginning, we wanted to connect and create a Hispanic Latino council. These were dreams that I had, and so did one of my bilingual moms. for about 4 years. And so this was the perfect opportunity. We pulled together one of our health outcomes researchers. We had one of our population health um, staff members and also a community engagement coordinator come together on the team, which really did help think outside the box. Um, and so, as I said, we wanted to originally bring in those um, unheard voices of our Hispanic Latino families. And, we had come up with different ways we were going to do that. And then things changed. And as you said, the federal landscape really took a turn, making those families and those communities feel very unsafe. So we had to come back to the drawing board, think outside the box, and say, okay, we can't bring these individuals into our walls. We need to go to them where they feel safe. How can we do that? And because of connections that our community engagement coordinator had already made with one of our community support systems for the Hispanic Latino population, we were able to get pulled in to go to monthly Hispanic Latino wellness clinics. And so we decided that we were going to take information to them, and then we were going to start asking them, you know, some key questions. And what I realized was families from these populations, they don't use typical text message and communication tools like we do. They use WhatsApp because it's private, because it doesn't take data. Um, and so we have begun building that trust, giving them information that they didn't know about things that would support them by us as a hospital. And now we're able to gather their feedback, still going to where they are comfortable, attending parent groups and things like that. And so the tools, the team, it has really been of great benefit. Um, and I've been doing this for 9 years and I learn every day, but this has really, really helped change the landscape of the way that I'm going to be connecting with different populations moving forward.
Thanks so much, Teresa. We have a question from Linda in the chat that I just wanted to bring to your attention. She's, hoping to learn a little bit more about bilingual and Spanish-speaking member involvement, and just wonder, kind of practically speaking, how did you do the nuts and bolts of the outreach and plans for non-English speaking members participating?
So, not having a formal group, we and it just being organic, I'm utilizing my bilingual family partner to help me speak with those families because she is from Puerto Rico. So she has those roots, and letting them see that she trusts me and letting them know that I'm there to support them. Um, that has been of big help. The great thing is that within WhatsApp, that information, you can create groups and I have many of our families that we've connected with. I have many families contact information to have a group that I can start sending questions to, and them knowing that the only information that I will share is their feedback that will be completely confidential of who has given me that feedback, other than the Hispanic Latino population.
Thanks, Teresa. It sounds like having that bilingual family partner was a really key aspect of kind of creating that trust and relationship. Um, And Alicia, I'm so excited to see you raising your hand based on your comment in the chat. I was hoping that you would. So if you wouldn't mind unmuting and sharing your comments.
Yes, I was very happy to see that I'm not the only one that's working on a project like this. So last year I partnered with many of our bilingual hospital staff, and that was key for recruitment. So I had a social worker, a child life specialist, and a nurse. And that was who had the relationship with the families, that the family was then comfortable because it was coming directly from that relationship, organically having the conversation. It also worked out in my favor that our PFAC coordinator for the whole health system is also bilingual. So that was wonderful. I unfortunately am not, and so I did the legwork, but could not participate in the meetings and such. But I was able to do a lot of the translation. But that was the key piece, was having the buy-in from some of the staff PFAC members that have the relationship with these non-English speaking families. And again, like Teresa had mentioned, this is a huge population here in New Haven, Connecticut, that up until now hasn't had a voice. And I'm proud to say that this is the first non-English speaking council in the entire health system. So hopefully with more of these conversations, more and more will come popping through. But it's been fun. So Teresa, I'm so glad to hear that you're in it, and I think that it was a project well worth taking on.
Thank you. It was amazing. I will give you an example. We our first parent group that we attended, the community support is named El Puente. And the first thing that we took to them entering into our respiratory season was information that had, yes, been translated into Spanish. However, it takes more than just having a piece of paper given to someone to truly understand what the services are all about. So I talked to them. We educated them about not having to go to the emergency department for pink eye or for, a urinary tract infection or the common cold. We have different services like urgent care, and we have a pediatric version of a minute clinic called a Kids Express. And these families, they ask questions I wouldn't think, can we go if we're not documented? Do they accept cash payments? And will they bill us? And we got those answers for them, gave it to them. And I talked with the director of emergency services about a week later, and she says, they're coming. They are coming. We had not seen them before. And every time we tell families about that, their eyes are lighting up like big saucers. And it feels good.
Thank you so much, Alicia and Teresa, for sharing a little bit about that. Kanisha, I know that your hospital has also done some work, so wanted to just send it over to you to share a little bit about what you all have done.
Cool. Thanks, Pam, and thank you, Teresa, for that great intro on what you've been doing. So I am Kanisha. I'm representing the Kamansky Children's Hospital, which is actually part of New York Presbyterian Weill Cornell in the borough of Manhattan of New York City. And today we are freezing, so I hope you are in much warmer climates than the rest of us. What I wanted to do was to share the three main successes we have, and I apologize because I'm in a public space. The first is our ability to adapt. Really, when it came to it with terminology and the changing political climate and administration, we realized that we wanted to have the same impact and do the same great work, but not get caught up in semantics. So we are now known as the Culture and Community Committee, which is very much representative of what we're trying to do. We're trying to, get those perspectives, have representation, and really make sure that we're serving the communities across the board. The other thing that we did, and Teresa touched on this when it comes to adaptability, is offering different means of communication. WhatsApp has been fantastic for being able to be nimble, to understand the immediate needs of the most underserved and marginalized communities that we serve. And so that has been amazing in being able to get those resources to our communities. The second part of it is really down to Pam and this great group of the IPFCC of being able to really focus in on what are those SMART goals that we want to achieve. How are we going to elevate our PFACs? How can we collaborate together to learn from each other and then get really pinpointing on what we can do? So with this cohort, we were able to look at the three main goals and priorities, and that really helped us be more impactful, which I'll get to in a bit more depth when I talk about the work that we're doing. And then the third, which is extremely key, is partnership and alignment. So the collaboration that we do here is also very key in the hospital. We meet with our chief of pediatrics, we meet with our leaders, we work with social work and clinical child life services. And this is especially key because what we want to do is that on a macro level, we want to align on what the hospital sees as their North Star. And similarly, we then take our goals and figure out how we can advance and accelerate by joining forces. And that has been absolutely key to us being successful. So now I'm going to change gear and talk about the actual work that we're doing. So we're in the favorite part of stage, in my opinion, which is execution. We love executing. We like to be impactful. We like to measure our impact. And we like to fail fast because it's all part of it, right? Learning and growing and continuous improvement entails some not succeeding and seeing that as an opportunity to learn. And so some of the things that we did, starting again, I talked about the terminology change, and that has been great. We continue to have the same impact. On the action plan that we did for the IPFCC and specifically for this forum, we came up with three goals. The first goal was that we wanted to be more data driven. So we thought we should start with data and end with data. And that's a great way to be quantitative in collaboration with the sentiment and qualitative aspect that we continue to do. So one of the things that we did is we sent out a voluntary self-identification form to 35 members of our PFAs. And we're very pleased to say we got 32 responses back. And that gave us a really good idea of our representation across the board, from everything from race and gender, language, as well as clinical expertise. And in that way, we were able to identify where we have gaps, where we're very strong in and where we want to continue. And that will then lead to our recruitment strategy, being able to update it and tweak it accordingly, which is coming up in the spring. The second thing that we wanted to focus on was using this information to say, in the communities that we serve at New York Presbyterian and in Wild Canal, when we look at Kamansky Children's Hospital, are we really representing all of the communities and where do we have gaps? And then recruiting to get that expertise in and those perspectives so that they can join as our PFA on our FAC. So that was the second goal, taking that data and using it to expand perspectives and expertise. The third is we realize, like all of us, we spend a lot of time and effort and we want a good return on our investment. So when we do recruit that talent and we get that perspective in, how do we retain it? How do we make sure that we are getting the best and optimizing the best out of that expertise, that we're facilitating a psychologically safe environment, that we are promoting an environment where people can contribute in many different ways? So what we did is we started doing more of a buddy system. We started creating squads of mini PFAs amongst ourselves to keep that connection, to keep the human element. We found a way to have a hybrid model where we do both in person and virtual, but we saw that the most effective way was to have all in person or as many and all hybrid, and that has worked tremendously. We realize, for example, in breakout sessions, that works very effectively over Zoom and using Zoom breakout sessions, much like we've done in this forum, and we've seen success. So we've implemented that. And again, we have gotten great feedback where people are able to contribute. We even have PFAs that live outside of New York State, and they've got to fly in, and they do, because we are able to have these forums of virtual contributions, advance notice for in-person, and that's made a significant difference. So taken together, this is where we have been successful. Recently, we met with our chief of pediatrics, Dr. Sally Permont. If you ever have the pleasure of meeting her, I highly recommend. She is a dynamic leader, and she's made time for us so we can talk about a retrospective. What have we done that we want to continue to do? Where do we want to go? And so what we've decided is that in partnership with our leaders, we want to expand our reach. And as New York Presbyterian, which consists of multiple hospitals, we want to help our other hospitals in Brooklyn and in Queens and find a goal to commonly align around so that we can share all the good stuff that we've learned at Kamansky, everything that we're learning from you, and we can share and partner with Brooklyn and Queens. And one of the common goals that we really want to align around is something that I'm sure all of you feel the same about, is around vaccinations and the importance of vaccines and educating and encouraging our communities to vaccinate because of the significant impact of not doing so. So that's really a little bit of a glimpse of to what we're doing. Happy to answer any questions.
Thank you so much, Kanisha. I think two questions. One is a little bit more general, and then one specific. So um, let's start with a specific, actually. What kind of funding support do you have from the institution or donors to support all of these efforts? That's from Linda, who wonders if you've secured additional funding.
Yeah, amazing question. So we had received corporate funding a few years ago, and we decided to use it to promote a social determinants of health initiative. This is an example of where we received outside funding, and we found a way to make it as impactful as possible for the communities. So for the social determinants of health, we have used that funding and used the questions from the American Association of Pediatrics to identify families in most immediate need and offer access to food, transport, and accommodation. This has been highly successful, and as a result, we have applied for funding with the Dalio Center. I'm not sure if you're familiar with the Dalio Center that was established to fight racial injustice. And we are the proud recipients of funding as of a couple of months ago, where we're able to take this further and take the next step with our social determinants of health in being able to use those funds to establish a more sustainable way to help our families beyond the immediate need in the hospital, but for the next 6 months in terms of food pantries, etc. So that's one example of where we get funding. We also very lucky in our communities that we do get donations of gift cards and vouchers that we can utilize for our initiatives. For example, we have a backpack initiative, and we get donations from people who want to give back, who want to help and see that what we do is very impactful. And we do that to promote initiatives that really impact our families.
Thanks so much, Kanisha. And Elizabeth, is that how you pronounce it? I see you have a question or comment.
I just wanted to share actually our experience in Winnipeg in Canada with our patient advisory. So I'm an emergency physician there for 30 years now. And 5 years ago, we started a patient advisory committee dedicated to pediatric emergency. And the recruitment initially was based on data. So who are the patients that we see that come to the emergency department? Wanted to make sure that we were well represented and sent out some recruitment posters to the different areas that capture, those who are primarily seen in our emergency department. And after the recruitment, our first task really was doing a survey, which was actually driven by the Picker Institute survey, the initial emergency survey, and was modified by the committee members. So once we had recruited, we sat down, we went through the survey with them, and we said, what's missing here? What is it that you would like to know about patient experience in the emergency department that's missing here? And so they brought in questions of psychological safety. They brought in, questions of language, et cetera. And we modified the survey. And this was also in partnership with the Bachelor of Science Medicine students who were taking the lead on this research. And the trifecta was the Children's Hospital Research Institute of Manitoba, the Winnipeg Children's Hospital, and the Children's Hospital Foundation. So 3 people who were supporting it from a monetary perspective. We launched the first survey and then identified the issues based on that survey that were most important to patients in terms of their experience. And we identified 2 that we thought we could action and then resurvey the following year. So give it a year. And 2 of them were really the patients wanted things in the waiting room to empower themselves, when they're caring for children, and they wanted, sort of modified discharge instructions. So we modified both of those, relaunched the survey, and saw a significant improvement in their patient experience the following year. So that was the first sort of task of the pediatric emergency advisory. And then since then, we've met 4 times a year, and we've achieved many things through that committee. So autism toolkit, language. Right now, we're working on a clinical pathway for immigrant and refugee families when they present to the emergency department, and what are those needs. And the issues are brought to the advisory committee both by the patients and families, but also by healthcare staff. On our patient advisory, we have our nurse manager, we have our educational assistant. We have people who can action some of the things that the patients on the patient advisory. Oh, it looks like I'm freezing a little bit here. But we can action some of those items as well. So, and it is a remunerated position. So the patients are paid for their time, and they're provided with, if they need, travel arrangements, parking, babysitting, etc. That's covered as part of the funding. The funding comes from the Children's Hospital and the Children's Foundation and the Children's Hospital Research Institute of Manitoba. So sort of all three contributing to it. So it's been a really exciting time these last 5 years in terms of trying to do this. I'm very excited about this toolkit though, because now I'd like to go back and see what we can modify based on the toolkit. One of the things we haven't done a lot of is the education for the advisory committee members, which I think is very exciting. And I think that would bring a lot of depth and richness to the committee as well. So I'm looking forward to looking at that toolkit. Mm-hmm.
Thank you so much. Just a quick follow-up question. I wanted to elevate something that Linda had brought up in the chat a little while ago, but just given that you were talking about the nurse manager and the educational assistant, the people who are involved, how do you get buy-in from other staff when everyone has a lot of different commitments, people are overworked? What has that looked like for you?
It hasn't been hard. We have a lot of people that are interested, in participating and things like that. So I think that from the staff perspective, and it's interesting because the staff aren't remunerated for their time. So I'm not remunerated for my time. The remuneration is strictly for the patients and families. And we feel that this is part of our job. So we haven't remunerated those positions yet. Of the healthcare staff, but maybe if funding increases in the future, that may be an option. But right now, it's really the remuneration really is going to our patients and families.
Thank you so much. I also want to draw attention in the chat. So Christina had asked about feedback from others regarding the onboarding process. And so just kind of asking everybody in general, maybe to think about this, and if you have something to share, in addition to standard hospital orientation, what other specialized training do you provide? And as I'm quickly reading down the chat, I see from Vicky that you all offer a health literacy training for advisors. Hi, Vicky, always good to see you. Would you mind sharing a little bit about that?
Hi. Oh, sure. Also, I do want to say, because Pam, you know my program well, we actually streamlined it, and our advisors do not receive the regular hospital training, because when I came on board, I found that it was actually too burdensome, and it was a big barrier to how to recruit for diversity. So I just want to say that out loud because it just came up. I'm sure you're wondering what we do, but we have streamlined it significantly to make it more accessible for all of our communities. And then in regards to health literacy, I put in the chat, I'm really fortunate on my team. The health literacy specialist is on my team, and we found that we wanted to train our advisors in health literacy, so when they're actually sitting on committees and councils, that they are actually interrupting the process when the employees are creating and talking in jargon or in things that won't make sense for patients. So we really wanted to empower them so that they had the language around health literacy in plain language, just when because we were like, well, they can be health literacy advocates. Like, why are we just relying on our employees and our system to be health literacy and literate. We're like, let's make sure all our advisors are. So that's been new in the past about past year, but it's been really helpful.
Thank you so much. Others, are there things that people have to share about their onboarding and training of advisors and what has worked for you or some things that you all have thought about? Yeah, Emily.
Well, I'm retired, but when I worked in person and family centered care, onboarding and training patient partners, we tried to give them a very comprehensive introduction, which I gave a little bit when I first talked to them, and then we would have a meeting where we would go for like 3 or 4 hours, and it included things like what is the Kaiser Permanente system? Where did it come from? A little of the history and how it works, so they know what they're getting involved in. The whys of patient and family feedback, why it matters, and some of the ways that we bring it in that they might be invited to. We talked about unconscious bias, how everybody has it. It doesn't make you a bad person, and the importance of being just aware of it as you're working with people who you may disagree with. And then also we did a lot of work. A lot of it from me came not in person, but like consciously say, you got to meet with me on Zoom if you want to be a patient partner. Why? To train them how to get onto the system whether it's on the phone or the tablet or a computer, so that when they get invited to an online project, they know how to do it, and we don't have to spend the first 20 minutes getting people onboarded. Those are the main things.
Thanks so much, Emily. And Linda.
Thank you. I just wanted to share that we've sort of found a shortcut for members to participate. We start them off on Zoom meetings primarily, and so the onboarding can happen sort of in tandem and in parallel. What we found that was that the hospital onboarding is primarily targets on-site volunteers, right? And so because my PFAC members don't come on site, or at least not initially, they could sort of do that in tandem and still participate in PFAC meetings over Zoom. So that's really expedited things.
Thanks, Linda. I also see in the chat from Amanda, who noted that as a standard process for all advisors, they're required to actively participate in an advisor orientation and a storytelling workshop that are 3 hours each. Amanda, I don't know if you're able to come off of mute and share a little bit more about that with the community.
For sure. We have an orientation that was developed in partnership with some of our provincial teams and the standards that they went with. And in efforts just to make things more consistent across the province, we developed something that is both site specific, PFAC specific, and aligns with our kind of provincial health standards and objectives across our province, because we are a provincial entity. The other thing that we did put in place is a storytelling workshop. It really helps with people just understanding how and when to share their stories, what's most appropriate to share. And for those who might be a little more apt to sit quietly through a meeting instead of speak up, this is something that's really helped people find their voice. People who have expressive aphasia or any other sorts of potential like brain injuries or things like that found that very useful, because it helps them organize their thoughts a little better. And this is something that we've gone with just so that people are interested and able to readily share that story. And sometimes people enter an advisor role before they're actually really thinking about what that means, because they're sharing a story. It doesn't always mean that they're ready to. Sometimes they're too triggered. I've had people take that storytelling workshop and just say, "Ooh, this is way more than I thought it was." And being this vulnerable in a setting is not for me, and I'm not able to do this. So it's a good way of just really figuring out how that could look in a meeting as well.
Thank you, Amanda. And I think that can also be a really nice way of allowing advisors and providing a spot for them to share information about themselves that is important and really create an environment that is welcoming of different perspectives and different experiences as well. That's great. And Teresa, I see you have your hand raised.
Yeah, I know. One of the things that we collaborated and changed um, year before last with volunteer services is we found that it was, of course, very difficult for families to come in during the day to get those volunteer service education, the health screenings if they're going to be virtual or in person, because we have hybrid meetings and background checks. And so what we have done is we do an annual onboarding event because we recruit once a year. And we do an annual onboarding event in the evening that is a one-stop shop. Um, and we allow the families to bring their children if they need to. And so they can get all of their training. We've worked with our employee health to have the lab request already put in if there needs to be labs drawn, which makes it a lot more convenient for especially our working families. Um, the other thing that we have recently started doing is we just had a conversation week before last with volunteer services to see if there was any reason why, any legal reason why we needed to go through them for our volunteers, um, or if there's a way, because I do family partner training with them and that's all virtual. So they're looking at changing some things to make it more convenient, but also inclusive.
Thanks, Teresa. And I saw also just wanted to note in the chat, Darnasis said that they also do a storytelling workshop, but he noted that they've been able to waive health screening for virtual advisors for the health system. And Darnasis, I don't know if you're able to come off of mute, but I know that this is something that we've heard from people, is often a barrier to participation. And if you can share anything about what was the process like of being able to waive that health screening for your virtual advisors.
Yeah, sure. We ended up having to go through our legal department as well as work very closely with volunteer services in our health system office of OHS that does all of our occupational health as well. And so we had to get kind of approval from all of those entities in order to make it happen. So it took quite a while, but essentially that has been a big barrier between getting a lot of our advisors in because some of them, for instance, shy away from actually getting like a flu shot and stuff. And so those are individuals that could affect the diversity of our membership. And so we heard it, really loudly from a survey that we sent out to our advisors, and so we tried our best to get it into play. And then we were recently able. I think we started that in October when we were able to get to move forward with that, which has allowed us to get a lot of our advisors through much quickly.
And Darnasis, could you say a little bit more actually about the survey that you sent to advisors, kind of what you were asking and in what context you heard that feedback from them? Because I think that's such an important part too, is reaching out to the community and trying to figure out in what ways is this working and in what ways is this not working?
Yeah, so it became a real very stringent for us to get the health screenings, and so we had some of our advisors that were stepping down because it was something that had to be happen every year, and so we sent out. We have a group of about 1,200, what we call our virtual advisors that only participate in surveys, and so we sent the survey out to them asking them what would prevent you from being more active or participating on committee work or storytelling events and things like that. And a lot of them said some of the requirements that they have to go through, like the training, our flu shot that they have to do yearly, the background check that has to happen. So some of the other stuff we weren't able to change, like background check and actual have them go through a training, but we have been able to at least lift one of those concerns that were preventing a lot of people from participating in various fashions.
Thanks, Darnassus. And I appreciate the information about you really kind of trying to learn what some of those barriers to participation were and getting that feedback. Um, the chat is amazing, as it always is on these conversations. Way back when we were talking about Hispanic and Spanish speaking advisory councils, I know, Dawn, you mentioned some of the work that you've done at Cincinnati Children's. And I know that you all have done some incredibly thoughtful work. Would you mind just sharing a little bit about that? I think I saw Carla here too, who is always wonderful and amazing, but thought it might be helpful for you to share with the community some of what you all have done.
That is so generous. Thank you. So much wisdom. It's hard to know whether to speak or listen. So I would not be speaking except you pull me out. And Carla is here. And I also, just in deference to where the expertise lies, I invited Carla to be the voice of this work. And she encouraged me to speak up because my role in the organization is assistant vice president. So I don't do the day-to-day work, but our team has consistently thought it was important to recognize that the organization has to, at the executive level, commit to the work. And so she's like, you need to be a leader. And so I'm like, okay. What we did in our recognition, probably now 4 years ago, 5 years ago, that we were not, our advisory councils did not include all voices, was we needed to say that they didn't, and then decide there's something obviously that we need to do differently. And it took a very important kind of step to hire engagement specialists who were also representative of the community. So it was our history to have a lot of white women be the kind of champions of and support for our family advisory councils, the facilitators. And as a team, we were like, no wonder our councils look a lot like our leaders. So then you mentioned Carla. So intentionally hiring into leadership roles for family advisory facilitation and engagement folks who, so we have Janita, who is an African-American woman, and we have Carla, who is a Latina from Guatemala. And then we have Emily, who is a white suburban mom. And I have had on my whiteboard since 2018, having a family advisory council that was in Spanish. And I couldn't execute on it until hiring Carla 3 years ago, because Carla can represent the community. She is bilingual and went through the training to be an interpreter. I mean, she lifted so much to bring the community to a forum, and then from the forum to the other decision-making spaces in our organization. So in March of 24, she brought forward members of the Spanish-speaking community who are already our patients, recognized that it was heavy Mexican American or Mexican immigrant, and so then diversified beyond that. So we have 7 different Spanish-speaking countries represented on the the family forum. It's all in Spanish. It is done by interpreters, so our monolingual English speakers come, but we are the ones listening through simultaneous interpreting. That is done through our language access team. Their partnership has been, we couldn't do this without them. And when the meeting is only in Spanish, meaning the presenter is also Spanish speaking, I don't go. But when it is interpreted, I am present. I am, and this is in part to say out loud, the organization commits to listening to our Spanish-speaking families. And the thing that Carla would, I think, want me to say is that now we're a year and a half in, almost up on 2 years, right? It's almost March 26th. This community now sees themselves as representing all our families who speak a language other than English or use a language other than English. So their answer to everything is no longer it needs to be in Spanish. They're pressing our organization to use visuals and support that actually doesn't require reading at all. So the open, what am I trying to say? Their advocacy has supported our families who don't read English, as well as our families who, and that I wanted to share. And the other thing we do for sure, oh God, look at the time, I'm so bad, is the honorarium is really.
Oh, I think Don froze. Don, you froze, but I think you were going to say that the honorarium is really important.
The end.
Thank you so much, Dawn. Yes, we are at the top of the hour. These conversations always go so quickly. If you are not a member, please do join PFCC Connect. We have a way for the community to ask questions, but also you will learn information about these conversations, resources we post there, and access to the recordings, of course. Next slide, Matt. So what is next? Look for recordings, slides, and chat to be posted on PFCC Connect. We do always post the chat because it is so robust. Please continue the discussion. We'll put a post there. Email resources and links that you might have related to this to me. That's how you can get in touch with me, pdardis@ipfcc.org. Deepa or Jasmine, would somebody mind putting in the toolkit link one more time? Because the other action item is please do check out our toolkit and check out the resources. We would love to hear about how you are using them along the way. And then our final slide, please do not leave without completing the evaluation using the QR code here. You can snap it with your camera. We'll also put a link in the chat to this. There will be a link in the email that's sent out as well. We do take a look at this. We use this information to make sure that we are addressing topics that are of interest to this community. And finally, before we send everybody on your way, thank you so much for being a part of our IPFCC community, for sharing generously your knowledge, your experiences, your resources. We are all in this work together, partnering with patients and families, and it is truly through the strength of this community that we are making progress. So thank you for each and every one of you who has made the time to be here today and for the work that you do. We really appreciate it. Hope you have a wonderful afternoon.
Thank you, Pam. See you. Bye.